Hello, and welcome to my lecture titled Behavioral Interventions to Increase Vaccine Demand and Uptake. My name is Dr. Neetu Abad. I am the team lead for the Demand for Immunization team here at the U.S. Centers for Disease Control and Prevention, or USCDC. And I'm really excited to talk to you about a topic that I care a lot about, that I've spent a lot of time doing, and that is on behavioral interventions. Next slide, please. This is a little outline to give you a sense of where we're going today together. First, we're going to talk about behavioral science and how behavioral science is applied to health behaviors. We'll talk about vaccine demand as well as interventions that increase vaccine uptake. Talk about some interventions that we have identified in the literature as being effective, and then also give a sense of monitoring and evaluation that you can do whenever you implement a behavioral intervention. Next slide, please. So it's my hope that when you leave this lecture, you will learn principles of behavioral science and how it is applied to designing, implementing, and evaluating behavioral interventions. Learn what behavioral interventions are most associated with increasing immunization uptake, and learn how to implement behavioral interventions, taking into account the realities of the field work that we do, the challenges that we have, and the opportunities that are also present in our work. Next slide. So what is our core organizing problem statement when we're thinking about behavioral interventions? Well, when vaccine uptake rates are lower than what we expect, and we know that some of these factors are due to behavioral or social drivers, what interventions can we use to increase vaccine demand and uptake? So this may be the situation that you find yourselves in. Importantly, you may have already done some of the exercises to identify and utilize localized behavioral insights, meaning you have done your rapid community assessments, you've done your surveys, and you know what the main drivers are of low vaccine demand and uptake. Next slide, please. So let's talk a little bit about behavioral science as a discipline and what that brings to the table and how we can best use the tools in behavioral science to increase vaccine uptake and demand. Next slide. So what is behavioral science? Well, behavioral science in the context of public health can be defined as the science of conceptualizing, measuring, and changing health behaviors. Next slide. So you can see here that, not only is behavioral science concerned with a range of health behavior outcomes, but that in fact, many disciplines go into what we know as behavioral science. So you have behavioral economics, communication science, anthropology, I would also add sociology here, psychology. And each of these, circles has a long history of research, science, and practice behind it that people are trained in. So it's interesting when we say behavioral science, we're actually referring to a huge collection of academic and applied disciplines that come together to create it. Next slide, please. All behavioral science really has a few fundamental components. A lot of it is theory-based, meaning that a theory is a set of interrelated concepts that explain behaviors and suggest ways to achieve behavior change. So there are many theories that exist in behavioral science, and I won't really go over them today, but there's a lot of reading you can do to get really familiar with some of the dominant kind of theories that are present in behavioral science that help to guide our action. We are really concerned with research. We want to bring data, quantitative or qualitative or both, to bear to understand gained via theoretically informed approaches. And we want to put this into practice. This cannot just live in a textbook or live in a classroom or live in a university. This has to, intersect with our reality of how we do work in the field. And so these are interventions to induce positive behavior change, which are informed by theory and research. So this is kind of where we land, is in the practice of behavioral science. And this is what we all do together. Next slide. So I wanted to point out actually a situation where behavioral science got it wrong because it informs some of the trajectory of how behavioral science comes to be and where it's going. So next bullet, please. So I want to talk a little bit about the information deficit model. Created in the 1970s, the information deficit model assumed that gaps in understanding between scientists and the public, well, that's the core reason or the result of a lack of information and knowledge. So the fact that, this is the belief that it's the lack of information or knowledge about something is what is leading to problems in terms of behavior and why people aren't doing what they're meant to do. So the intervention naturally then would be a one-way communication model where information flows from experts or people who are called experts to the public in an effort to change attitudes, beliefs, or behaviors. So let's think about this, this hypothesis about the information deficit model. Next slide, please. Okay, so I want you to raise your hands if you have heard, if somebody has ever told you or if you have read that working out at least 3 times a week is a great way to stay healthy and fit. So have you heard that? I certainly have heard that. Next bullet, please. Okay, now keep your hands raised if you yourself work out, exercise a minimum of 3 times a week, every week that you're alive. Okay, I have to put my hand down. And I'm sure that many of you have to put your hands down too. So why is that? If we have heard and we know that it's fact that exercising a few times a week is fantastic for our bodies and our health, why is it that every one of us don't do that every single week? Well, next bullet, please. It's because behavior is determined by so much more than knowledge and information. It's determined by culture, religion, emotions, memory, past experiences, the logistics of our daily life, the way that we interact with the world. There is so much that influences our behavior more than information and knowledge. And we're still struggling with the kind of the legacy of the information deficit model in behavioral science and in public health. Because there is this kind of erroneous assumption that it's information is going to make people do the right thing or people do the thing that we want them to do. And it's knowledge and fixing those issues is going to get us where we want to go. And we have seen time and time again that does not equal behavior change. Next slide, please. So let's talk about more specifically around vaccine demand and uptake and what are some interventions that we do know that can influence vaccine demand and ultimately uptake of vaccines in communities that we're working in. Next slide. So first, let's start with this vaccine behavior continuum. And the word continuum is really important here. We see here that you have a continuum ranging from refusal on the left to demand on the right. And, refusal can be sort of, I don't want any vaccines ever. It can be, I don't want that vaccine, but I'll take these vaccines. There's a range of behaviors when it comes to refusal or even delay. And then on demand, it's sort of like, I'm going to be first in line. I'm searching for those appointments. I'm going to make sure I get vaccinated. I really want to be vaccinated, or this community really wants to be vaccinated. Well, very rarely actually do we have those two extremes. In fact, before COVID, the extremes were not as evident. But during COVID vaccine rollout, you can see that we actually did have some of those sizable groups. But even with COVID vaccines and really all other vaccines, we have this big group in the middle. These are called the wait and see folks. So they're not necessarily opposed. They're not necessarily totally into it. They're sort of like, I'm not sure. I'm just going to wait and see what happens, make my decisions later. Maybe I have questions, concerns. I need to get those addressed before I make the decision. So it's this middle group, what we have called the movable middle. They are so vital for our efforts to build vaccine demand and uptake because they are a really reachable group. Next slide, please. So what are some of the behavioral and social drivers of vaccine uptake as we understand it? So this is a model, I'm sure you've seen it now several times in presentations and how people talk about things. It's a hugely influential model on the work that we do in the field of vaccine demand and uptake. It was created by a group of experts working on a working group chaired by WHO. A lot of people had a lot of input into this, and it's also based on a very long history of survey research and other types of research in behavioral sciences that have come up with these core kind of factors that are associated with vaccine uptake. So we have on the top left, we have thinking and feeling, and that's kind of how worried are we about the disease that we're preventing from, getting vaccinated? What are our feelings about the vaccine itself? How confident are we in the vaccines, including the benefits of the vaccination, vaccine safety, the trust that we have in the vaccines? All of that is captured by this top left box. And I would say that's actually where we have placed our emphasis on many kind of decades of work on this topic. But increasingly, we see that it's not just our individual perceptions that really make a difference when it comes to vaccine uptake. It's also all these other things. For instance, in the green box, you see social processes, social norms, what people around you are doing, what you think they want you to do. Whether or not you're getting a recommendation from a trusted healthcare provider, whether issues related to gender equity, or in the US, we have a lot of discussions around racial equity, race and ethnic equity, whether those are kind of influential or impactful on your behavior. And then all of this kind of leads to different motivation to get vaccinated, right? So, or different motivation to follow advice. And all of this is met with these practical issues, as we call them. So is the vaccine available? Is it affordable? Do you have a difficult time trying to get it, or is it easy to get? How are you treated when you go to the clinic or when you interact with the health system? Do you have a history of negative interactions, or are you, greeted with respect and dignity when you go seek health services? All of these issues are really important and can make a big difference, even if you have high motivation to get vaccinated. If these things are out of place, we see people fall out and not be able to kind of follow through on their intention to be vaccinated. So all of this leads to vaccine uptake. And it's really important to remember these drivers or factors when we're designing interventions and the thing that we want to change. Next slide, please. So this is what we call our ladder to building demand. These are the necessary ingredients for what we need to do from an intervention side of things to make it so that people are getting vaccinated on time. So we want vaccines to be accessible. That's that practical factor box. We want to make them easy to get, easy to access. Just ease of access is very important. Making sure we're overcoming any obstacles, that they're seen as beneficial, that the health benefits of vaccines are seen as important and salient and real, that it is convenient, that we're reducing any out-of-pocket costs, social costs, opportunity costs, all of those kinds of things, that it's seen as a convenient thing to do, which is kind of tied to access. That it's seen as desirable or something that you want to be engaged with, or normative. So you're doing it because a lot of people around you are doing it. Or in some cases that it's necessary, so that you have to get vaccinated to do the things you want to do. And that's when we get into discussions around vaccine requirements and different other policy issues or kind of policy things we can put into place to make it so that people get vaccinated. The important thing to remember about this ladder to building demand is that you don't want to reach for those top rungs unless you've really done what's on the bottom rungs of the ladder, meaning you have to make sure that vaccines are accessible, that the services are convenient, that they're seen as something you want to be engaged with before you start talking about requirements that can have a backlash effect. Next slide, please. So a little bit more information about this, which I'll cover some aspects of this today, but there's a lot of information out there and there's a lot of research that has been done and research that still needs to be done on identifying some of the most prominent strategies when it comes to this. So you've got combating misinformation, sorry, I'm going to move this box up here. Combating misinformation, engaging in effective communication, employing some kind of financial incentives, having vaccinations delivered, at your doorstep. So that can happen a lot in vaccine campaigns, but it's also the case where there could be mobile vaccine vans that are going to households with different kinds of antigens to be able to vaccinate people at their house. Having a provider recommend vaccine as a routine part of visits, that can be very important. Having medical reminders, so that means maybe getting a reminder out from a clinic to have somebody come to get vaccinated or return for a subsequent vaccine. Motivational interviewing being a strategy that really encourages effective communication, specifically between providers and caregivers, but also between people in their community, making sure that a provider is recommending, like I said, having vaccinations available in schools and other community-based locations, having vaccine ambassadors. So these are people in the community that are championing vaccines or sharing their testimonials, vaccine requirements, so mandates, and then also vaccinations that are based in the workplace or that are available at work and encouraged through your employer. So these are just a collection of 12 strategies that came, to the top of the list when we were putting together a guide of all the best available recent evidence for promising and proven practices. So I really encourage you to try to access this guide and read more about some of the underlying research that went into identifying these strategies as being really important. Next slide, please. You notice that a lot of the strategies I just showed you, they really rely on this concept of trusted messengers. So trusted messengers, they effectively deliver messages, but also have a lot of strategies that go along with it to reach people. They can validate the credibility of information, help address mis and disinformation, help create a feedback loop for addressing concerns and questions from the community to the health system. And they are a very important gap between healthcare providers and patients and caregivers, and that they're really vital. So a lot of the strategies I talked about kind of rely on this concept of trusted messengers. Next slide, please. Here's an example of or here's sort of like the description of vaccine ambassadors, and we'll talk about an example that was published. But vaccine ambassadors are one way that you can train community members to disseminate important health information in their communities. Ambassadors are most effective when they are trusted in their communities and they share similar beliefs and characteristics with their peers. So you have to kind of choose these ambassadors carefully. Why was it included as an important strategy? Well, when people think that most people around them want to be vaccinated, they are more likely to be vaccinated. So that's the power of social norms. Endorsements from peers in one's own social network can also help spread credible information about the vaccine. So these are a couple of different research findings that sort of bolster the importance of vaccine ambassadors, increasing vaccine demand and uptake. When you think about some of the barriers to vaccine uptake, an intervention like this can really address issues related to equity, to access. They can change social norms in the community. They can address issues of mistrust, curb mis and disinformation, or at least address it, and have a lot of relevance to the particular culture that they're representing. Next slide, please. So this is an example of one of those vaccine ambassador interventions. The Motivate, Vaccinate, and Activate campaign encouraged residents of the under-resourced or underserved, predominantly Latinx Mission District of San Francisco, California, to be vaccinated against COVID-19. Community health workers educated the community about the vaccines, texted people to let them know of their eligibility, and used public media to spread the word about vaccination locations. These efforts helped increase vaccinations and overcame hesitancy due to misinformation, distrust of institutions, and access to the vaccines. So you can sort of look more into this particular intervention to learn about it. But what I really like about it is that it's not just information. They were texting people, they were reaching people to inform them where they could get vaccinated. So they were linking access to a public kind of enthusiasm campaign around COVID-19 vaccinations. Instead, usually that multi-pronged effort that we see is going to work more effectively than just using one method alone. Next slide, please. So let's talk a little bit about vaccines that are delivered at the house. So these are situations where we bring vaccines to where people are, including in their homes, as an effective means to reach several hard to reach populations. So some of the barriers that this kind of intervention type can address are issues related to equity, to access, kind of that inertia. So maybe there's some desire to do it, but you kind of get caught up in your life or your sort of routine, and you don't actually do it. And any friction, so any kind of obstacles that may stand in your way between you and the vaccine. In an intervention like this, individuals canvass specific communities to educate people about the flu vaccine and offered it to people on the spot. So they focused on people with substance use disorders, immigrant populations, older adults, sex workers, people experiencing homelessness, et cetera. Some of these really hard to reach populations. And there was increased interest in receiving the influenza vaccine, especially among members of hard to reach populations. And I'm not sure if this particular intervention documented an uptake effect, but they certainly were able to increase motivation to get vaccinated, and they were reducing barriers to access and other issues that might prevent members from hard to reach populations to actually get vaccinated. So this is, combined with the information, but also, getting community members mobilized, giving them a very specific way to get vaccinated tends to result in better outcomes. Next slide, please. So let's talk a little bit about monitoring and evaluation, and on kind of when you have chosen an intervention, how do you want to monitor the progress on that, the progress you're making on health behaviors and how the intervention is rolling out. So in addition to sort of process outcomes, so like meaning information that you're gathering as you go along your intervention, that's very valuable information as well. How many people you're reaching, kind of impact you're having. There are ways to track progress on kind of those social drivers, but behavioral social drivers of vaccine, as well as a vaccine uptake. So next slide, please. One of the ways you can track what your intervention might be accomplishing is by looking at the movement of these kind of BESD indicator, priority indicators of that BESD model I talked about earlier. So you can see, is your intervention succeeding in increasing risk about a particular disease? Is it increasing the confidence that people feel in the vaccine or in the vaccine's benefits of the vaccine? Is it convincing people that vaccines are beneficial? Is it changing the way that people around you are thinking about vaccines, or people, in the intervention setting or location are thinking and talking and feeling about vaccines, or what they're doing? And, is it changing any kind of motivation to get vaccinated? Are people sort of moving more into a motivated state to get vaccinated? And then if your intervention is acting on some practical issues, do they, at the end of your intervention, do people know where to go? Do they, maybe understand that the vaccine is for free if it is, et cetera? So in many ways, you can think about assessing these items at the beginning and at the end of your intervention. It can be difficult to move the needle on these, so you would not expect to see movement on all of these. But if your intervention is specifically targeted at a specific driver, and you really want to change something about the way that people feel about vaccines, then you need to have some way of measuring their kind of perceptions before and after the intervention. Next slide, please. And there are also in that similar BESD framework, there are also priority indicators for routine immunization. So we just looked at the ones for COVID. There are similar items for assessing, on childhood vaccination and any sort of routine immunization. You can use the similar indicators. So, and I'm sure you've been shared some resources about where you can read more about these types of indicators you can include and items you can include in your kind of assessment approaches that you'll take to intervention evaluation. Next slide, please. So I want to do a little bit of a deep dive into a particular intervention that I have been involved with. Next slide, please. So this is improving interpersonal communication between healthcare workers and caregivers. And we did this project in Romania. It's actually ongoing. We wanted to design, implement, and evaluate a motivational interviewing-based intervention that increases immunization uptake among children 6 to 15 months of age. And motivational interviewing is also part of a larger group of skills kind of known as interpersonal communication for immunization, or IPCI. And these are a collection of important communication related skills that healthcare workers can have to increase vaccine uptake. So, we had various steps along this project. You don't necessarily just go in and implement an intervention, right? You want to do some kind of needs assessment or get a sense of what the community really needs. Either that can come from your behavioral insights work, or you specifically go and figure out if the particular intervention you're going to do is going to be accepted or seen as acceptable by the community and important community stakeholders. We implemented the actual training once we designed it based on the needs assessment. we are in the process of evaluating the training and associated kind of skills from that. And really importantly, you want to make sure that you're disseminating your findings to other people and other stakeholders and other communities, and the same communities from which you did your research. Next slide, please. This is kind of a snapshot of some of the training curricula that we developed. We have orientation to immunization challenges, understanding factors that influence attitudes and behaviors towards immunization, some description or understanding of the vaccine hesitancy. So some of the things I actually talked about with you today, that continuum, some of the things we may do to combat vaccine hesitancy. A module on how to communicate around immunization. So not, everybody knows how to explain the way that a vaccine works or really address questions and concerns. We did a lot of prepping healthcare workers to do that. Talking about communication in the health facility, and this is an important way to practice what you have learned, so that we've given you this information. How are you going to actually use it using skills of motivational interviewing? Thinking about what caregivers need to know, so some of those concepts, and then also communication that takes place outside of the health facility. So what happens when you visit someone in their home or do any community-based work as a healthcare worker? How do you handle those types of things? So those are kind of a general snapshot of what we did. Next slide, please. And what we wanted to do was see an increase in coverage of the Hep B series of vaccines, and the third dose particularly, as well as the first dose of MMR. And we chose those specifically because of where they kind of are on a child's timeline, where they're given in the first and second year of child's life. We also were really interested in understanding if we could improve immunization-related knowledge, attitudes, and practices among caregivers, assess the quality and effectiveness of the types of communications that they were having with healthcare workers, and make sure that healthcare workers are really improving their own interpersonal communication and counseling skills that they were using with caregivers. So this gives you an idea of the goals that we set for ourselves at the beginning of the intervention before we did anything, is kind of what are some reasonable goals. I would say that 10 to 15% increase is incredibly ambitious. It's probably something that I would lower in the future because it is really difficult to get major increases from a singular intervention. It's usually not reasonable to expect large increases, but incremental change. But we were really also hoping to see some improvement in attitudes and practices and beliefs as well. Next slide, please. This is kind of just a snapshot of the timeline of evaluation that we used when we developed this project. And there's some statistical calculations in terms of, how many people you want in a baseline group, how many people, in an end line, how many healthcare workers, how many caregivers. There's like a little bit of, math involved in that. But essentially at the baseline, we wanted to do CAP surveys, some of these knowledge, attitude, practices surveys. We also wanted to evaluate right after the training what kind of knowledge and skills the healthcare workers had. We were also looking at vaccine registry data to see what the coverage was in the places that we were doing this intervention. So this all occurs between, caregivers and healthcare workers were our target kind of populations here. So you can see at baseline what we did. So then 12 months later, 12 months can be a sort of a typical, a year can be a typical observation period where you do a baseline and then 12 months later you do a follow-up or an end line. And so you can see here that we have CAP surveys again after 12 months, for both healthcare workers and caregivers, but we also added a qualitative component so that we can capture some of those things that don't come out as clearly on a survey, right? So we can probably look at, what kind of communication skills are you using? How confident do you feel on addressing caregiver concerns? Look at some of those BES indicators of, do you feel that the vaccines are safe? Do you feel that they're effective? All those kinds of things, but to really get at, how are you interacting with caregivers? What are those interactions like? Tell us from the caregiver perspective and the healthcare worker perspective, what challenges are you still having, after a year, after kind of being given these intervention tools and having some supportive supervision and all these things involved, with the intervention. So that qualitative component was incredibly important for us to capture in addition to some of this quantitative pre and post. And then we're also going to be looking at, pulling information from a vaccine registry out to see what sort of changes there are in these, general locations where we're doing the intervention. This, I would say, is on the more complex end of an evaluation for an intervention, and it took a lot of resources and time for this. You can do less complex evaluation designs, and hopefully in other sessions during this training, you're going to get exposure to what those are. But these are some ways in which, if you're really interested in doing a deep dive into an evaluation and an intervention, these are some of the tools you can use in order to get there. Next slide, please. So let's talk about, we've really kind of taken a nice journey today through behavioral science, through the field of vaccine demand and uptake, and talking specifically about intervention design, implementation, and evaluation. What do we know to be true in the field? Well, one is that messages are not going to save us. We know this, that we need to build political commitment for strategies beyond just risk communications to change vaccine behavior. You need to have strong risk communications as part of any strategy, but we also know that there are techniques and strategies that go beyond that, that are more deeply into community engagement and improving the relationship between systems and communities. COVID-19 has in many cases interfered with community members' ability to access services. Some have suffered loss of income or other logistical challenges. Reducing out-of-pocket costs associated with accessing health services is really, really important, especially when it comes to uptake of other vaccines that are not just COVID. Remember that power dynamics in a community change during an emergency. Trusted messengers are so important, but they are not the same all the time for each, for a community. They can change over time. So you need to pay attention to how your community evolves, how the emergency is impacting your community, and incorporate these changing dynamics into your intervention. So it might be that a particular community leader or religious leader before an emergency carried a lot of importance and influence, and maybe that's changed as a result of the emergency. So you need to understand that the concept of trusted messengers is very dynamic and is not necessarily always stable in a community. Next slide, please. So what are some kind of best practices when you're thinking about doing behavioral interventions? So first, you have to find ways to listen to the community and bring that listening into intervention planning, implementation, and evaluation. And I really started this lecture at a point where, maybe you've already done that listening, you've collected those behavioral insights. That takes its own time, and making sure that your intervention also has a needs assessment component, even if you already have that information, to make sure that the specific components of the intervention you're considering map onto what the community finds acceptable and desirable. So that listening happens at various stages in your intervention kind of journey. You want to work with a variety of trusted messengers and make sure that you're accessing different types of trusted messengers who are going to be a part of what you're doing in a community, and making sure to document and disseminate your interventions and evaluations, and making sure that others are inspired by what you're doing, and that you're sharing your results and you're sharing your impact data, and that you're importantly sharing it back to the communities that you worked with during intervention. Too many times researchers and practitioners come in and do some sort of complex thing and then leave and don't actually leave a legacy of learning behind. And that can really sour relationships with a particular community. The next time somebody wants to do something, they'll remember that feeling of not being involved as stakeholders throughout the entire process, and it may affect whether they want to engage in the process in the future. Next slide, please. So we've talked about, I know you've seen this in various other lectures. What can you do in different resource environments when you have access to different things? So in the mountain bike scenario, which is maybe some of our lower resource environments, you want to make sure to choose an intervention that sort of makes sense with the resources you have, but still addresses a high priority, high impact challenge. Look for ways to incorporate interventions into people's existing roles and positions. So if motivational interviewing or other IPCI tools are something you're interested in doing, well, can you talk to a social mobilizer or train a social mobilizer who's already out there in the community and just give them some extra skills to use on the job? Moving up a level in terms of resource, you can think about maybe piloting your intervention in a couple different locations. Typically, when I am starting out to look at where to do an intervention, I want to choose districts based on maybe population. So rural, urban, semi-urban, or a peri-urban. These are, important distinctions, because what works in a rural environment won't necessarily work in an urban environment, and vice versa. And there can be various other ways that you contrast, you pick contrasting places. Including evaluation data wherever you can. And I would honestly say that is true for every level of this. Making, if quantitative is difficult to do because surveys can be more challenging, can you do some qualitative data collection and get some evaluation data that way? And that can include, focus group discussions with the people who are implementing the interventions, with community members, with community influencers, all that kind of thing. Although I don't think quantitative is only for the high resource environments. I think it can be relevant at every step, depending on how you do it. And then let's say you have a lot of resources and you have a lot of desire to really get into this work. You can think about, in addition to locations, now think about differing populations. So maybe you want to work with a migrant group or a refugee group, or maybe you want to work with an urban high density population, or pick your populations of interest and of importance, and you can pick a few of those and try out your interventions there. And then you can also include more complex evaluation data like the ones we've discussed today. Next slide, please. So these are some key references. There's quite a lot out there on these concepts that I've discussed today. There was a paper published in 2021 that has a lot of information about, strategies that really work to increase vaccine uptake. But even every day, there's more and more resources that are sort of out there and being shared when it comes to designing and implementing and evaluating behavioral interventions. Next slide, please. So what are some key messages or key things that we can remember when it comes to behavioral interventions? So behavior related to vaccine uptake is really highly complex. It's very context specific. We do need more evidence. We need more people doing this type of research out there to see what works to increase vaccine uptake. It is still true, unfortunately, that a lot of our research comes from high income countries, and we need a lot more people to understand the operational environment in low and middle income countries and document approaches that work. That's very important for this field to move forward. When you are designing interventions using a behavioral model, such as, the BES framework or other models that are out there, can help you structure intervention and expected outcomes based on what that model, kind of theorizes about the world and how behavior actually occurs. So these are some of the things I really want to leave you with. And, it's been my absolute honor to talk with you about this topic. It's something that I have loved working in and that I have a lot of passion about. And I know a lot of other people do too. So I wish you all the best as you're thinking about how to incorporate these types of principles in your work.